Sure, great. Well, I would like to welcome everyone to the North Carolina Pediatric Society webinar on early periodic screening, diagnostic, and treatment program. We are so excited that you are joining us today to learn more about this very important program and talk about how we can work to make transformation work for kids. We have my name is Dr. Susan Mims. I am currently the Vice President of the North Carolina Pediatric Society and a pediatrician working with Mission Children's Hospital in Asheville. And I will introduce our other panelists. We have a series of a lot of people on the phone participating who represent health plans, pediatric providers, and other people interested in child's health who would like to learn more. So we're very happy that you're here. Our panelists will consist of some experts from across the state in child health. We will hear from Dr. Marian Earls, who is a developmental behavioral pediatrician and works with Community Care of North Carolina in Raleigh, North Carolina. Dr. Scott St. Clair, who is a general pediatrician in Boone, North Carolina, with Blue Ridge Pediatrics and Adolescent Medicine. We will hear from Christy Street, MSW and a certified care manager who works with the North Carolina Pediatric Society with our Fostering Health North Carolina program. Michael Riddick, who is an MBA and EA, is a practice manager with Goldsboro Pediatrics in Goldsboro, North Carolina. Dr. Christoph Diazio is a general pediatrician with Sandhill Pediatrics in Southern Pines, North Carolina, and Dr. David Taylor III, a general pediatrician with Coastal Children's Clinic in New Bern, North Carolina. And before we we're very thank you to all our panelists for joining us. And before we get started, I would like to run through a few technical logistics issues with the webinar. To reduce feedback from the phone lines, everyone except the speakers will have their audio on mute, and you can ask questions through using the chat box on the webinar screen, and you can ask questions at any time. We will reserve some time at the end of the webinar for answering all questions that haven't been answered. Let's see. As we get started, we'll have each speaker hand off to the next speaker. So with that, I think I wanted to say again how excited we are to share some elements of the EPSDT program with you today, and especially what's been working in North Carolina. The North Carolina Pediatric Society has a wide range of members. We're about 2,000 in membership. We have pediatricians that practice in independent and hospital and academic practices, as well as public health, and a wide variety of membership from across the state. And one of the things that we all share in common is an appreciation of the value of the early periodic screening and diagnostic and treatment program, and how having this program for our children with Medicaid is absolutely critical to ensure that our patients get the services they need. As pediatric providers, we see every day how this program helps us identify issues early and intervene early, which with this focus on prevention and early identification, EPSDT helps identify and then prevent more serious and more costly conditions later on, and helps ensure that children with Medicaid are set up for success in their health and in their life. with this, you will hear today about a wide variety of the services that and how we have been working through the program for years in North Carolina to make sure children have the access to medical, dental, behavioral health services. And especially for the children with Medicaid who are at greatest risk of having health and social and emotional challenges, how this program really sets these kids up for the greatest opportunity for success in life. So with that introduction, I will turn it over to Dr. Marion Earls to talk a little bit more.
Thank you, Susan. This is one of my favorite topics. So let's start it. I want to make sure we have time for all of the discussants. So we can go to the next slide. So a little bit about North Carolina EPSDT. In North Carolina, EPSDT is called Health Check. And North Carolina Medicaid has a long history of working with our chapter on clinical priorities and child mental health and payment and immunizations. That goes back many, many years of the society. We've really enjoyed this collaborative relationship. And as a result of that, Medicaid has over the years enhanced the content of the EPSDT visit to keep it close to what national child health priorities are coming out of the American Academy of Pediatrics. And our North Carolina Health Check Program Guide, which has been recently updated and is on the DMA website, actually outlines all our EPSDT requirements and coding, and has a periodicity grid for primary care clinicians to be able to follow. Next slide. This is a little busy. I just want to make a comment here about the Health Check Coordinator Program, because these are coordinators who are very much integral to the success of our EPSDT, in that they have a mandate to do outreach to both members of Medicaid and also to primary care clinicians. Originally, this was a county-based program, but has been associated with the CCNC networks for some time. And historically, they would remind folks after somebody realized that kids had missed appointments. But what we've done as an enhancement to this with CCNC analytics is we've developed care alerts for the folks to use, which is actually more proactive. So it's identifying kids who are due as well as kids who are overdue, so that they can focus on getting kids in at the appropriate times for their well visits. In addition to that, we've given them care alerts that are flagged and filterable for children who are in our priority populations, kids with special health care needs. And you can see that those listed there: asthma, foster care, kids with sickle cell disease. And we have a particular interest in transition age youth who have special health care needs, and being certain that they transition to adult health care seamlessly as possible. So health check coordinators really function almost as community health workers. Many times they're in practices doing this work. They may be embedded like that. They do home visits in some counties. They really do tremendous outreach to get kids in for their care. They've, in many counties, also partnered with the school system to make sure reminders happen in that way. Finally, they also are, oral health is another area where they are mandated to get kids in for dental visits, and we'll talk a little bit more about that. So next slide. So as I mentioned, North Carolina EPSDT has a periodicity schedule pretty consistent with Bright Futures, except for most Medicaid programs. It still doesn't include that prenatal visit that's on the Bright Futures schedule. But I want to call attention to the well visit components that North Carolina EPSDT has identified and has in its program guide as things that should happen at the visits at the times that you can see here. I'm not going to read the whole list, but you can see they're very interested in development and behavior from infancy through adolescence. and as well as the traditional things that are part of well visits, vision and hearing screening, BMI percentile, immunizations, and lead screening. So next slide. So we have pretty robust metrics for EPSDT as part of CCNC's quarterly measures and feedback. We are able to give data to networks and for all of their practices for QI purposes. So this data comes out quarterly. It includes the, quote, EPSDT profile, which you just saw that list, something about asthma medication ratio, which is a HEDIS measure, and then there are also measures for oral health. We are able to also filter the EPSDT profile for children and youth in foster care, and you'll hear from Christy later. That's something we supply to the Fostering Health Program and also to networks and practices, so they're certain that children in foster care are getting those needed services. And finally, we have just started sharing data with networks and practices on their patients with sickle cell disease. And so you can see the profile includes all of those well visit rates, the well visit components, and then our oral health components, which include the annual dental visit and then the dental varnishing that's done in the primary care practice. So the next slide's a little busy. I'm not going to read all of this for you, but you can see this is a sampling of the fourth quarter of 2017 and the first quarter of 2018 data that would be received by the networks and practices. These are our overall state rates, and they're compared to our HEDIS benchmarks, which are the HEDIS mean benchmark. And so you can see that we have well visit rates. HEDIS doesn't have a rate for 7 to 11-year-olds, but we're trying to promote that age group is going to their well visits. So we've included a measure for an annual well visit for 7 to 11-year-olds. The BMI percentile screening is something that we've been promoting and hope to expand. This actually requires that practices would use a Z code for BMI percentile for us to be able to get that out of claims. Our lead screening, we've worked very closely with the lead program here in North Carolina, and we'll be having quarterly lead data available probably in the next quarter. We have immunization rates, and then we have rates around our developmental and behavioral and social emotional screens. And you can see there that we have some pretty impressive rates around that. I do have a note about our autism screening rate. Because of changes in billing code, our claims are looking different. But for several years, we were at about 80% of the time that people were doing that. And you can see we're very pleased that screening adolescents for depression, which is a new area for many practices and for our measurement, has been steadily increasing. Next slide. Then there are oral health measures here. So we give folks information about the annual dental visit, and we specifically break out the annual dental visit for 2 to 3-year-olds because we've been encouraging folks to make sure that we're meeting that AAP guideline to try to get kids with a dental home by age 1. So you can see that we are above the HEDIS mean for that age group and very pleased with that. And then we have this measure of dental varnishing. North Carolina was one of the first states in the country to start doing dental varnishing in our Into the Mouth of Babes program. The Peds Society, Family Medicine partnered with our folks at Public Health and Medicaid years ago to train practices in dental varnishing. And our measure looks for children by age 3.5 having 4 or more varnishings, because the evidence is that if during that time period they have that fluoride varnish, they're less likely to have caries. We have been partnering with Public Health consistently over the last several years to help with training of practices and updated training of practices as they get new providers and so on. We've coupled that dental varnishing with technical assistance to practices on how to refer and connect patients to a dental home, which is, again, reflected in our 2 to 3-year-old rate. overall, at all ages, our rates are above the HEDIS mean. And you can see our asthma data there on the asthma ratio and data on our sickle cell patients. There's not HEDIS measures around this, but we are trying to encourage patients with sickle cell disease to see their primary care clinician as well as to see their specialist. And we want to see those rates going up. You can see that they decline as patients get older, and we see that into the adult years as well. And so the state is doing some very innovative work with us to get folks their care. So I think that's the last. No, there's one more slide. Next slide. So just to point out in our metrics, our areas of excellence are around this developmental screening. We are probably the highest in the nation for that rate. And that includes both pediatricians and family medicine physicians. Maternal depression screening, we're fairly unique in the country in doing this, in measuring it, and are achieving really high rates, as you can see in that second bullet. Adolescent depression screening, I mentioned, is steadily increasing, and our annual dental visits and dental varnishing are really a highlight of the work that we've done around connected with EPSDT. And I think that's it. And we can go to the next.
Great. Before Scott jumps in, this is Susan Mims again. There is one technical item I wanted to share, that this webinar will be recorded, and to let folks know that it will be available on our website probably in a week or so on the North Carolina Pediatric Society website. So with that, take it away, Scott.
Yeah, so my name is Scott St. Clair. I'm a pediatrician up in Boone, and just wanted to talk a couple minutes about behavioral mental health in the primary care setting. Everybody who does primary care knows that this is a challenging aspect of practice. And just to give you a little bit of perspective, about 10 years ago, our practice got a grant to have co-located mental health in our practice. And this provider started coming to our office just a couple days a week, and in a very short order was full-time 5 days a week and totally full. And he eventually ended up bringing on 2 other people. So at one point we had 3 full-time mental health counselors in our practice. And during the time we had that, it really helped on several fronts. Number one, it really helped with access. So our ability to get kids in a timely manner for help was great. And the other part was the coordination and collaboration. Just being in the same building, literally just around the corner, allowed us to manage these kids really, really well with maximal amount of communication and collaboration. So we had a glimpse of that for a few years, and then as the mental health landscape changed, particularly around, I say paperwork, computer work, forms that needed to be filled out, our mental health providers just felt like they could not continue to see who they were seeing and be able to do all the reporting requirements. And so we eventually lost our co-located mental health providers, and we've really struggled since then to maintain that same level of quality. Obviously, we can refer them out, but it has not been nearly as good on access and not nearly as good on the collaboration when we've had to do that. So that's just a little bit of perspective on my end from what is possible with co-location, but also some of the challenges when you don't have that in your office to really provide robust mental health services. So I think that's it on my end.
Excellent. I think we'll move on to Christy Street.
Great, thank you. Hi, I'm Christy Street. I'm the Program Director with Fostering Health North Carolina, and we have been with the North Carolina Pediatric Society for the past 4 years, so starting in 2014. And our goal with our program is to increase the health and well-being of children and youth in foster care in our state. We're using a medical home model, which is based on the guidelines from the American Academy of Pediatrics, Healthy Foster Care America, which dictates that children and youth in foster care should be seen early and often, should have good continuity of care and coordination of care, so that they can get the specialized care they need given the amount of trauma and ACEs that they've experienced in their lives. We make sure that we're linking the appropriate stakeholders involved, which include primary care providers, the Departments of Social Services in our 100 counties, our community care of North Carolina networks, which provide care management, as well as a lot of other stakeholders involved in the lives of children in foster care. We want to make sure that they're getting appropriate developmental as well as behavioral health and social emotional screenings, and getting the type of care that they need so that we can offset some of that risk that they have having been through trauma, which sort of lays out poor outcomes in their adulthood as far as physical as well as behavioral health and mental health outcomes. And so we try to connect those pieces to provide education, training, and technical assistance to all the stakeholders involved so that we can help to meet those needs of this complex population. And in North Carolina, we have kids that move from county to county and can be complex in getting behavioral health care the way that our system currently works, as well as getting that good continuity of care. So it's really important that we're putting those pieces together.
Wonderful. Thank you, Christy. We will move along to Michael Riddick.
Great. Thanks, Dr. Mims. Thanks, everybody, for joining us. I am Michael Riddick. I'm the administrator at Goldsboro Pediatrics in Wayne County. And I'm going to talk about the administrative process under EPSDT, which primarily for our providers involves prior authorizations for testing, such as a patient comes in to one of our pediatricians following EPSDT guidelines. They feel like a test, let's say an MRI or a CT, ultrasound needs to be performed. You know, the process for that, and actually right now the ease of that process, which is a beauty in of itself right now, considering how so much works for us in insurance and whatnot. But so right now, like I said, a patient comes in, a provider feels like something else should be done under EPSDT, like a CT. The process is very easy. They request the CT or the prior authorization for the CT under a website. One of our staff members will go to the website. It used to be called Med Solutions. Now it's called Evercore. The beauty of it is there is one form to request all prior authorizations. Very easy to understand form. Generally, a staff person will help the physician complete it. Requests are diagnosis driven quite often, and we get a very quick response. It can be nearly immediate, approved in seconds. At times, some additional information might be required. And because it's, again, an easy process in one website, we can upload additional information like the visit, etc. And they can generally make a pretty quick call on that. If they deny it, pardon me, then there is an appeals process that we can have a peer-to-peer review with the physician, and that can take some time, but that doesn't happen very often, and it's still very efficient overall, the process is. So to kind of walk through it, the beauty of the process in and of itself is it's one process, it's one form. There's not 15 different types of forms we have to fill out. It's not a confusing process. It's easy to understand. It doesn't waste staff time or provider time, or more importantly, it doesn't waste the time for the patient or the parent that's brought the child into the office. In the winter in Goldsboro Pediatrics, you might have 10 to 20 of these requests a day for prior authorization. And you can imagine if it was a burdensome process, how that could slow down the process, or it could make it difficult for us to provide additional information on the test itself and the approval to a patient when they've left the office. So quite often with this demographic, we're able to we're able to get approval, share the information with the patient while they're still here in the office, as opposed to trying to catch up with them later. And most importantly, going forwards, because of the ease of this process, we really just want to make sure that it's continued. Like I said, one website, one form, very easy to follow. So we've been very happy with this process historically. So thank you.
Wonderful. Thank you, Michael. Now we'll move on to Dr. Christoph Diazio.
Yeah, hi, this is Christoph Diazio. I'm a general pediatrician in Southern Pines, North Carolina, in independent practice. And so I'm very interested in data quality, trying to use computers for good rather than just annoyance. And I think one of the great strengths that we have in our current world with Medicaid is that all our patients have the same data pool that is analyzed by sort of a single entity and has access to all the data. And so I think one of the things that we're concerned about with the coming Medicaid change is that as patients will transition from MCO to MCOA to MCOB to straight Medicaid back to MCOC, is what will be the common point on all those data points, and how will each individual MCO be able to manage the data that is sort of in different sort of silos in different organizations. And so making sure that all that data is good. The other thing that's going to be important is that for some of the data that's not claims-based, sort of how are we going to handle that? And then I think another thing that's going to obviously be important is who is impaneled onto what system, because in the current world, it's difficult sometimes to know who the patient is impaneled with, because there are still some patients that are still straight Medicaid. And so since in the new system, presumably each MCO will know which doctor is assuming primary care for each patient, making sure that we have accurate data, excuse me, to know who really are our patients and which ones we're responsible for, to make sure we have accurate data will be critical. To pick up on the comment about foster children, that's a great example of the current world, because we have essentially different companies managing mental health for geographic regions of the state. And as children move around in informal kinship care and switch doctors, how do we know who the doctor for the patient is when they're moving, and how can the people providing care to that child get paid? So I think the data quality issue is really important, because we're sort of used to, in our existing world, having a level of data about our Medicaid patients that is quite frankly often higher than what we see on the commercial side as far as our cooperation from existing CCNC. So I think one of the things that's really important for us moving forward, if we're going to sustain these gains of EPSDT and continue to improve on them in North Carolina, is to make sure that there's transparent, seamless data, and that when we move to the level of being graded on some of these things, that it's data that we're also able to verify, because at least my understanding of the current world, in my opinion, is that there's going to be multiple opportunities to sort of drop the data ball. And so anything we can do to work with our partners to prevent that from happening is certainly something I'm interested in. So that's it, and I'll hand it off to the next person.
Great, thanks. Dr. David Taylor III.
Great. Thank you so much for having me, and thank you for attending as well. I'm David Taylor. I'm a pediatrician in New Bern. And what I was going to talk about today is the importance of having strong networks for our Medicaid patients. So having strong networks with access to pediatric subspecialists and ancillary services is vital to the health of Medicaid recipients. Just to illustrate the importance of this, I'll briefly describe the case of a patient in our clinic a few months ago. She was a 16-month-old who was in daycare, and as is true with the vast majority of daycare attendees, she had frequent colds and upper respiratory infections. Each time she became ill with the slightest cold, however, she developed significant stridor and a croupy cough. That's the that you hear children do when they get sick, and some respiratory distress, actually requiring steroids. So after the fifth or sixth time we saw her for croup, she was referred to our local ear, nose, and throat specialist, who's right around the corner from our office, and was able to see her in the next day or two for evaluation. The ENT was able to put a small scope down in the office and discovered that our patient had a bunch of papillomas or masses blocking the majority of her upper airway. The general ENT was not in the business of managing these papillomas, so he quickly referred her to UNC Pediatric Ear, Nose, and Throat, where she was able to be seen in the next couple of days, and she was taken to the OR within the week for surgery. So access to the appropriate specialists in this case and many others, and timely intervention were critical in this case. In this case, illustrates key points about provider networks. So the first big point I'd like to make is there are some specialists, such as ear, nose, and throat, orthopedic surgery, dermatologists, who see a lot of the pediatric patients that are referred to that specialty, and they're very, very comfortable seeing them. PE tubes that children get for frequent ear infections, ear, nose, and throat, any ear, nose, and throat can do that. So as is in the case in New Bern, where I practice, these specialists are often in town, making it easier and less costly for parents to make appointments, and probably less costly for the Medicaid system as well. So it's really vital as we're moving forward that these providers remain in PHP networks, and ensuring good reimbursement and limiting administrative burden are going to be essential to keeping these providers, a lot of whom don't see a huge percentage of Medicaid patients in PHP networks. And then the point number two, the majority of pediatric patients who are referred to specialists, however, have to see pediatric subspecialists. A couple of my friends are adult GI specialists here in town, and they are actually forbidden by their malpractice insurance carrier to see anyone younger than 17. So sometimes it's not them, but pediatric patients most of the time need to see pediatric subspecialists. Unfortunately, there are not that many of them. I can count most of the pediatric urologists in NC, for example, on the fingers of one of my hands. And most of these specialists practice at academic centers or metro areas in North Carolina. So these pediatric specialists, they either need to be in the coming networks, or you guys are going to need to figure out a way to get patients for whom you will be responsible to see these specialists in a timely fashion that is not a huge pain for all involved. And then the last point I'd like to make is that many Medicaid patients receive necessary care from other local specialists, such as speech pathologists, physical therapists, and occupational therapists, just to name a few. And it's essential that these ancillary care providers are in PHP networks. A lot of these providers do lack the infrastructure and the administrative staff to deal with the confusing array of requirements and bureaucracy and red tape. So ditto to the point made above, these services need good compensation and administrative ease if they are going to continue to see Medicaid patients and care for them in the towns where the Medicaid patients live. So quick in summary, ensuring that pediatric patients get the necessary services they need is a little bit complicated. On the one hand, many ancillary care providers and general specialists, such as ENT, take care of most pediatric patients in locations close to home, and that makes it less costly and easier on everyone involved. On the other hand, most pediatric patients referred to specialists need to see pediatric specialists who are often located some distance from home. So in order to provide quality care to pediatric patients, PHP networks need to have access to all of these specialists for children to get the care that they need. All right, that's all I have. Thank you very much.
Great. Scott, do you want to facilitate us through some questions and answers?
And people can
Sure.
write in the chat box if they have any.
Yeah, so I'm happy to facilitate that. If there are questions, I'm assuming we're doing all of that through the chat box. Are there any questions that people have?
So at this point, there aren't any, but do folks have points they would like to reiterate or stress, or questions you have of each other? So Dr. Earls, you talked about dental varnish. It's my impression that North Carolina has a particularly strong oral health program. Can you talk about some of the things we did to get there and the types of supports plans Mike could offer to practices to help keep us strong in the area of?
Sure. As I mentioned, the Into the Mouth of Babes program goes back, I'm afraid that I'm going to say the wrong number of years, but it's at least a dozen years. And if anyone else knows the exact years on the line, I've asked you to tell me that. So there was a partnership with the School of Dentistry early on with folks there who were really interested in trying to get to kids who were arriving at school with a lot of caries, and kids who were not necessarily getting into dentists, particularly in communities where there weren't pediatric dentists seeing very young kids. So this was very important work that involved collaboration with Medicaid, with dentistry, with primary care practices, and with the professional societies. It was some of the most innovative work, but the big emphasis was to pay primary care clinicians for doing this in a way that would encourage people to be able to incorporate this into their well visit schedule with young children. And it was very, very successful. As I mentioned, we were one of the first states in the country. There are still states trying to get this started in primary care. So we have tremendous experience with that. But what's been very important is that there was consensus that how important this activity was to prevent much more costly dental caries and need for acute work in children's mouths to be able to prevent that from happening. And so the commitment of Medicaid to pay primary care, to allow the dental CPT code to be used in primary care, really facilitated this happening, again, both in pediatric and family medicine practices. So I think that there needs to be continued support for this. I think that all the pediatricians on this webinar can probably attest to the change that they saw. I think I'm the oldest, however, so I would say that it was noticeable in the years that we've done this in the practice that I was in, which had virtually 96% of our patients had Medicaid. You really saw much less of children coming in with bottle mouth, with needing restorative work very early. It doesn't completely eliminate it, but it makes a huge difference. So I think from a return on investment perspective, it's something that needs to continue, however our Medicaid is configured in the future.
You make an excellent point, Marion. This is Susan, and I know that we have looked at the data for Western North Carolina. I'm in Asheville, and in the years, it actually goes back a little further than you're remembering, but I think it's like 15, maybe even 20, getting close to 20 years, 15 years, I think at least. And when we looked at the data, we definitely saw a dramatic improvement in the dental caries in the school-age children, and especially the kindergarten showing up, and that definitely translates into better health and less costly procedures on the dental side. We still do have some challenges with access to dentists and taking Medicaid, and that continues to be a challenge. With that, I actually wondered if any of the other panelists want to comment on any of the ongoing challenges that we face with this program. Any of the opportunities we see with any particular age groups. If no one, I am happy to comment a bit. I think that we have had very good success working tightly with care management, especially through the community care program that was developed over the years. And I think that especially in our hard to reach children, children who might be falling through the cracks, the opportunities to work closely with a strong care management team is something I see to make sure we're not missing kids, we're not missing their vaccinations, their well child care, and making sure that their chronic diseases are managed timely and well. Any other comments, or do we have any other questions on the chat box?
Still no questions. I think we can probably go ahead and wrap it up if you're willing, Dr. Mims.
Sure, great. So as we wrap up, I do want to thank our panelists and all the participants. We certainly hope that you have learned not just about the importance of the EPSDT program in prevention and early intervention for child health care, but also some of the innovative ways that our healthcare providers in North Carolina are using EPSDT to optimize the health and well-being of our children with Medicaid. And through our work with the North Carolina Pediatric Society, we have been very fortunate to have a great open communication with Medicaid and many of our insurers. As we move into Medicaid transformation, we really look forward to continuing an open dialogue with all of our plans that are participating in Medicaid, and having the opportunity to serve as a resource. Through the information shared today, you certainly have heard how important this program is. Absolutely essential to providing high quality, cost-efficient care for our children. And hopefully you begin to understand how plans can support a well-functioning Medicaid program, such as ensuring plans have simple, easy-to-use processes, have a robust provider network, have strong care management, working closely with our pediatric teams, and have a reimbursement level that encourages and maintains the wonderful access that we have in our state. So with that, I just want to say we really appreciate you joining us today and working with us to make Medicaid transformation work for our kids. Thank you so much.